Hi, thanks for joining me at Student Nurses Success. This video is going to cover some of the more common acute neurological conditions. We're going to talk about traumatic brain injury, stroke, seizures, some CNS infections, and hydrocephalus. Remember, you can find a link to the maps in the comments section. Let's go ahead and get started. I'd like to first begin and talk about traumatic brain injury. Traumatic brain injury is injury to the brain tissue that can cause swelling and eventual decreased blood flow to the brain tissue itself. Now, remember, whenever you have any change in either swelling in the brain or increased blood in the brain or increased cerebrospinal fluid in the brain, something has to give. And with traumatic brain injuries, what we see is the swelling from the injury starts to kind of push on the structures of the brain, increase intracranial pressure, and decrease blood flow to the brain. Now, not all head injuries are going to lead to a traumatic brain injury, but many do, and we do really worry about these. Prevention is absolutely essential when we talk about head injuries and traumatic brain injuries, because we know traumatic brain injuries can cause substantial disability. Common causes of traumatic brain injury include falls, sports injuries, maybe football, soccer, where maybe two people hit their heads together, motor vehicle accidents, firearms, gunshot wounds, and other types of trauma where the head is involved. When we talk about the prognosis of a traumatic brain injury, we really base the prognosis on the lowest Glasgow Coma score in the first 48 hours. We know that the initial injury is bad enough, but we also know that with any injury, inflammation can make it worse and cause increased swelling and increased intracranial pressure. So we do kind of watch that first 48 hours. So the patient may have some issues early on, but as that swelling continues, actually more brain injury can be occurring. So consider the main injury and also the secondary swelling that goes on that can cause additional issues. So you have your main injury that can cause decreased blood flow or swelling, but as that swelling continues and that brain needs to start to heal, that swelling can decrease blood flow to that brain and cause more ischemia and more issues. Let's talk about the other patho behind traumatic brain injuries. You can have what we call focal injuries or diffuse injuries. Now, focal injuries are more at the site of impact or the site directly opposite of the impact. When we talk about a focal injury at the site of impact, we call that a coup. In these particular cases, let's maybe talk about a motor vehicle accident where an individual slams and hits their head on the dashboard. So their forehead is where the coup injury is, the site of the impact. And we know there's going to be damage and injury and swelling at that frontal site of impact. And that's bad. But in some cases, we have something called a polar injury, which is a coup contra coup or an acceleration deceleration. So think about if you same injury where you're driving a car, you're in an accident, and the head hits the dashboard. But because of the sudden deceleration of the car from maybe hitting a tree or whatever object it hits, now the head slams backwards, and the back or the occiput of the head hits the back of the seat. Now we have two injuries at two opposite locations. You have the forehead injury, and the occiput injury. So now we have swelling and injury at two opposite poles of the head. This could be the same as maybe two temporal injuries. Maybe the head hits the side of the car and then it bounces and hits the other side of something. And so you can have two opposite of the temporal. So with a polar injury, you have two injury locations. With a coup injury, you have one site of injury. Now, a diffuse injury is widespread. So let's say you're in that same car accident and the car flips and it flips multiple times. Now, what's happening is that head has been hitting multiple areas inside that car and it's actually getting almost shooken up. We see lots of shearing and shifting of the brain. So the injury is all over the inside of the brain. It's in multiple areas because the car is flipping and turning and the head is bouncing around inside that car. Certainly, diffuse is much worse than even acute or a contracute because you have injuries throughout the whole brain. With diffuse injuries, the other thing we think of is the brain is suspended inside the skull by vessels. And if the brain is getting shooken up inside this car that's rolling and spinning, those shearing and ripping of the vessels is going to start to cause a lot of bleeding that occurs. So we really worry about that and that massive amounts of swelling. We also see diffuse injuries in things such as shaken baby. Um, and so diffuse injuries are much worse in nature because the swelling is all around the brain. Now let's talk about some types of injuries. We're going to talk about four in particular. The first is a concussion. The concussion is the most common, and a concussion is really defined by any alteration in LOC that's present immediately. So, any alteration in level of consciousness, and it's immediate. Now, this alteration in level of consciousness can be maybe you lose consciousness, or maybe you have a little amnesia, but it can also just be that you're kind of like a little shooken up or out of it for even just a second or two. Now, concussions, they can range from severe to mild and not very problematic at all. It just really depends on the mechanism of the injury. So anybody who kind of hits their head and is kind of a little out of it, even if it's for a second, that could be a very mild concussion. If you lose consciousness, it's probably a little bit more of a moderate or even severe concussion. After a concussion, patients usually complain of maybe some dizziness, maybe a headache, fatigue, tiredness, possibly nausea and vomiting, or even a little blurry vision. Would not have to have all of those symptoms, maybe one, maybe more than one. The thing about a concussion is if the patient does lose consciousness or seems to have a significant head injury that we are worried about things, we often then seek care and we will do a CT scan on them. In a CT scan, you are actually not going to see any evidence of injury to the brain if it is a concussion. There'll be no bleeding or bruising on the CT scan. So a concussion is kind of defined by lack of evidence on the CT scan. We often use the CT scan just to rule out worsening things like bleeding or bruising in the brain, which we'll talk about in numbers 2, 3, and 4. So if the patient has a concussion, we may do a CT just to make sure there's no worse damage. If we don't see anything, then we usually, and we know there was some type of head injury, then we usually say, they probably have a concussion. We do worry about repeated concussions. We know that when repeated concussions occur, damage can continue to happen in patients, especially if you have a concussion and you're still healing from that. Uh, a repeated head injury on top of that can really damage that brain that is really trying to recover from that concussion. So after a concussion, we usually want people to be completely free of symptoms for a period of time before they resume any activities that could lead to another concussion. The next thing we want to talk about is a contusion. A contusion would be a little bit more than a concussion, and we will actually see evidence on a CT scan of bruising of the brain, so that is worse. A laceration is worse. These actually get more significant as we move down this list. A laceration is some type of tearing or bleeding that we see in the brain from a head injury. And then the worst would be some type of hemorrhage in the brain, which is an accumulation of blood. There are three types I'd like you to know: the epidural, the subdural, and the subarachnoid hemorrhage, or often we call these hematomas. So for uh, an epidural hematoma is an arterial bleed. It goes very fast. We do see increased mortality. Often we'll see a skull fracture. Patients with an epidural hematoma, the symptoms right away, and the symptoms are usually significant. If they can seek care very quickly, then we may be able to minimize long-term problems or mortality. But it does, because it is an arterial bleed, we see the development very quickly. A subdural hematoma is a venous bleed. We see increased morbidity with those. So the problem with a subdural hematoma, it's a little slower, it's more of a leaking, and it develops over the course of 24 to 72 hours. So the symptom onset is longer. It takes longer to kind of develop symptoms, and they may be missed more commonly. A subarachnoid hematoma is a rupture of bridging veins that are deep inside the brain. We see these develop with aneurysms or a hemorrhagic stroke, where the patients maybe had high blood pressure and there's a rupture there of these vessels deep in the brain. These are much more serious in nature, and cause more damage. Let's move over and talk about stroke, or cerebral vascular accidents, or CVAs as they used to be called. Primarily, we just call them strokes now. With a stroke is injury to the brain from either lack of blood flow, an ischemic stroke, or from a hemorrhage, an accumulation of blood inside the brain. So we actually have two different types of stroke that we'll talk about: ischemic stroke and hemorrhagic stroke. With an ischemic stroke is from lack of blood flow, and usually it's from a clot that develops. So a thrombolytic stroke is from a thrombus or a clot that develops in one of the arteries or arterioles or tiny vessels in the brain that causes decreased blood flow then to a section of the brain. Or an embolytic stroke is a clot that has traveled to the brain and then lodges and becomes a thrombolytic stroke. With ischemic strokes, these are more common than hemorrhagic strokes. With ischemic strokes, we see cardiovascular risk factors being significant in the development or risk of developing an ischemic stroke. Specifically, even atherosclerosis or narrowing of vessels can cause thrombolytic strokes. We also know that with an embolytic stroke or a traveling clot that can lodge, hypercoagulability states, maybe if you have a clotting disorder where you're making too many clots, or atrial fibrillation. With atrial fibrillation, we know this increases the risk of developing a clot in the atrium that can then shoot up through the aorta and lodge in the brain. So individuals with a fib are usually on anticoagulation in order to minimize the risk of developing a stroke from their atrial fibrillation. So up here, I kind of have the risk factors for strokes include cardiovascular risk factors such as high blood pressure, diabetes, atherosclerosis, which all can narrow arteries and narrow flow of blood to the brain. And then I also have hypercoagulability states, sickle cell anemia, we know can cause more clotting, and ischemic issues, and AFib. The second type of stroke is hemorrhagic stroke. In a hemorrhagic stroke, this is where a vessel actually leaks or bleeds, and then you have bleeding into the brain, which is going to cause lack of blood flow to an area of the brain, and also an accumulation of blood in the brain, which increases intracranial pressure. It is not as common, however, high patients with extremely high blood pressure are at risk for developing a hemorrhagic stroke. With hemorrhagic strokes, you see higher mortality. With ischemic strokes, you see higher morbidity or the development of disability. Now that brings us to something called a TIA. A TIA is a transient ischemic attack. What a transient ischemic attack is symptoms of a stroke, but there's no residual effect. So there's no damage that's been done. They completely resolve. And with a TIA, there's maybe a tiny clot, but then it maybe dissipates or uh, actually gets reabsorbed back in, but there's no damage. So the patient will have symptoms of a stroke, but then it will resolve quickly and no damage will occur to the brain itself. These are warning signs for patients that they are high risk for developing a stroke down the road. So a transient ischemic attack is stroke-like symptoms, but it will completely resolve in a minute or two, and it is a warning sign that you are probably headed for a stroke or you have some decreased blood flow to the brain. Let's move on to the manifestations or warning signs of a stroke. So, really, what a stroke is lack of blood flow to an area of the brain, and a piece of the brain or an area of the brain is going to start to die from this lack of blood flow. And so, patients, depending on the area of the brain that's affected, could have different symptoms. They may have numbness or weakness in a particular extremity. They could have confusion, difficulty speaking. They could have visual disturbances if it's in the visual part of the brain. They could maybe have altered gait or balance or dizziness if it's maybe toward the occipital area or the cerebellum, which is responsible for gait. If they're having a hemorrhagic stroke, they usually complain of a severe headache or have a severe headache with it. You may not have all of these symptoms. In fact, it would be probably unlikely you would have them all, but you may have more than one. Now, remember, if your stroke is on the right side of the brain, maybe the clot is on the right side, you will see symptoms on the left side. So if the patient maybe has a clot on the right side of their brain in their right middle cerebral artery, their left arm would be the one that is not moving or that has numbness or weakness. And depending on if the issue is in maybe the frontal lobe, you may have processing um, difficulties. If it's in the middle cerebral artery, we see more motor, maybe more speech issues. So it just depends on where the clot or the bleeding is in the brain, and that's the symptoms that you're going to see. So, with stroke, we know that ischemic strokes are more common and they are left with a higher amount of disability. So, people generally survive from an ischemic stroke. However, they are left with often a significant amount of disability. With a hemorrhagic stroke, we do see higher mortality with those, but it doesn't mean that they wouldn't live or have disability as well. So, with stroke, we really talk about the sequela of stroke and the disability that individuals are left with after having a stroke. So, I've got here several that I want to talk about. The first of which is anopsia. Anopsia is visual field disturbances. Some individuals with stroke may lose parts of their visual field based on the damage to their brain or their visual centers. And so they may have some difficulty with visual disturbances. Agnosia is sensory disturbances that have to do with feeling. So they may lose the ability to maybe touch something and recognize it based on touch if they have agnosia. Aphasia is a pretty common sequela of stroke. Aphasia is difficulty or an inability to communicate. Now, aphasia can be one or the other, or possibly both. Aphasia can be fluent or non-fluent. Fluent aphasia means they can speak, but what they're speaking doesn't make any sense. So they're fluent, they're saying words, but the words are not fitting together well. We call this Wernicke's. Wernicke's aphasia is usually happens with temporal lobe damage or if the stroke affected the temporal lobe. Patients with Wernicke's or fluent aphasia have difficulty understanding what you are saying to them. They have receptive problems. They seem to be able to speak freely. However, the words aren't making any sense. A lot of times people call this word salad with the Wernicke and the W. So Wernicke's is fluent, can speak, but it's not making sense, and they don't generally understand what you're saying to them. Non-fluent aphasia means they're having very much difficulty getting the words out. They're having trouble speaking. We call this Broca's aphasia. Broca is often with frontal lobe damage or a frontal lobe stroke, or a stroke that has affected the frontal lobe. They can understand you for the most part, but they cannot express. They can't get the words out. They want to say something to you. They understand what you're saying, but they can't get the words out. It's extremely frustrating for them. And that is non-fluent Broca's. Another common sequela is plegia or paresis, which is difficulty moving one side. And we see this a lot if there's motor damage in the middle cerebral artery. So this damage on the right brain, remember, leads to left paresis or plegia, and damage if it's on the left side of the brain tends to result in right-sided paresis or plegia. Our fifth problem here, we'll just put a 5 there, is something called neglect. Neglect is hemi-attention. If the patient is experiencing or suffering from the sequela of neglect, it means that they don't even realize that half their body exists. They have completely neglected or are aware of either the right or their left side of their body. And it's a very, difficult. They may actually run into a wall because they don't even realize that that whole side of their body exists. Now, what I put down here in parentheses is something called an AV malformation or an aneurysm. Now, these are not strokes. So these are not strokes, but I put them here because if you have an AV malformation, which is an arterial venous malformation in your brain, it's a tangle where arteries and veins kind of combine, and they may start to leak and bleed. Or if you have an aneurysm in your brain that starts to leak and bleed, these are not strokes. However, they have symptoms and may present very much like a hemorrhagic stroke, but it is a different disease process that is causing them. So the patient may present with maybe difficulty speaking, or difficulty swallowing, or visual disturbances, or perhaps they have maybe paralysis or weakness on a side of their body. It could be a stroke. It also could be one of these issues as well. So I put these here. They're not strokes, but they're very similar and present like them. All right, let's move on to seizures. Seizures are abnormal electrical discharges in your brain. Just like if you have a dysrhythmia in your heart, that's an electrical problem in your heart. A seizure is an electrical problem in your brain. So the electrical circuit in your brain is short circuited and it's almost like in a loop, and it's causing this ongoing loop of electrical activity, and that causes seizure or motor movements. Causes of seizures can be idiopathic. We have no idea why some people have them. They could be related to a metabolic problem, maybe an accumulation of some type of metabolic, maybe if you can't process some enzyme, you're missing an enzyme, or you can't process some type of food or some type of amino acid, you can develop maybe seizures that poison the brain. It could be an infection such as meningitis. It could be from a tumor, or something in the brain that is pressing and causing an electrical discharge. trauma, head injury, TBIs, you can develop seizures, or even drugs can cause seizures, either illicit or prescription. With seizures, they can affect one side of the brain that we call a focal seizure. With focal seizures, patients usually remain conscious, somewhat aware, but they usually will have some type of repetitive, non-purposeful movement, like a tick or lip smacking or some type of little like twitch or something like that. A generalized seizure involves both hemispheres, and in most cases, that impairs consciousness. The most common, or what you think of with a seizure, is a tonic-clonic seizure, which is maybe a full body movement where the patient, the arms and the legs are moving. An atonic seizure, we call a drop seizure. That's when you lose muscle tone, you just fall to the ground. An absence seizure we classify as a non-motor seizure. We see this more commonly in children where there may be stare off for a few seconds. Or status is life-threatening. It's a long seizure, maybe greater than 20 minutes that doesn't stop, or seizures that you maybe stop a seizure and then have another one back to back, so repeated or back to back seizures. That could be status as well. Any type of status seizures, these are very emergent. They need to be stopped. After you're seizing for 20 minutes or so, you're going to start having brain decompensation and some damage there. With these other seizures, you generally aren't going to have damage per se to the brain tissue. They usually last less than a couple minutes and resolve. However, whenever someone does have a seizure, it does disrupt their learning. It disrupts what's going on. It takes them time to recover from that seizure as well. Infections, when we talk about infections in the brain, um, people who are high risk for having infections or pathogens that cross over into the brain are those who are immunocompromised, those who maybe have poor nutrition, or those who are exposed to vectors such as mosquitoes that carry things such as encephalitis. The two infections I want to talk about are meningitis and encephalitis. Meningitis is can be viral or bacterial. Fungal is more rare. Bacterial is much more serious. Meningitis is inflammation of the meninges. With meningitis, if it's bacterial, it is much worse. We see these manifestations: nuchal rigidity or pain with the neck, a stiff neck, positive Kernig's and Brzezinski sign, altered level of consciousness, petechial rashes that do not blanch, photophobia, and a very toxic, sick appearance. Bacterial meningitis is life-threatening. If we don't administer IV antibiotics quickly, patients will have high rate of mortality, and in most cases of bacterial meningitis, high rate of morbidity as well. With viral meningitis, it's more self-limited. Labs that we see with bacterial meningitis will see an increase in white cell protein in the cerebral spinal fluid and a decrease in glucose. Encephalitis is usually viral in nature. We see this like West Nile from mosquitoes. It is inflammation of the brain that causes the lysis of brain cells. Remember, meningitis is inflammation of the meninges, which causes maybe the development of pus in the cerebral spinal fluid, whereas encephalitis is inflammation of the brain. Manifestations of encephalitis includes increased intracranial pressure and fever. There's no antibiotics for it because it's viral usually, it's self-limited, although people can have ongoing disability related to it. Our last is hydrocephalus. Very briefly, hydrocephalus is can be either congenital or you can develop it after maybe an infection. maybe after meningitis, you could be left with the development of hydrocephalus, which is really just accumulation of cerebrospinal fluid in the ventricle of the brain, and it leads to increase in intracranial pressure and compression of the brain. So patients will have all those signs and symptoms of increased ICP. It can be either obstruction of cerebral spinal fluid flow or an overproduction of cerebral spinal fluid. We put a shunt in, which will drain the cerebral spinal fluid, usually into the peritoneal area. The shunt has a valve that opens when pressure gets high, and it will drain off the extra fluid and just kind of dump it into the peritoneal area. And often you can see these shunts kind of, if you turn the patient's head, you'll see the shunt kind of running down behind the back of their ear. And that's a pretty good overview of our acute neurological conditions. Make sure you view our other neurological video that kind of goes over some basics of increased intracranial pressure and manifestations of increased intracranial pressure, which you see in almost all of these neurological conditions.